So let's take a look at types of arrhythmias. So in this video, I'll be discussing about the bradyarrhythmias. So what is bradyarrhythmia? So there are two terminologies. One is brady and the other one is tachy. Whenever the heart rate drops below 50 and when the heart rate goes above 120, that is tachy and brady respectively. So in this video, we'll be discussing about the bradyarrhythmias, and so the heart rate for bradyarrhythmias is going to be less than 50 or 60 in some cases, depending on what textbook you're reading. So let's just imagine a 45-year-old male. He walks into your ED or a clinic, and he's in syncope, okay, and or maybe he's a little dizzy, and when you check the vitals for the patient, the BP is around 90/80 and the pulse rate for that patient is around 42, and the saturation is around 92. So now you can imagine that such a patient is having a big weird pulse rate. That means it is on the lower side. So this is bradycardia, and you then immediately take an ECG of the patient, and what you see is this ECG, okay, this one. So what can you figure, like what is weird with this ECG? See, I'm telling you that this one is our normal ECG, okay, and this one, the ECG that is shown here, it has something weird with it. The difference is that the gap between one QRS to the other QRS is very wide, okay, this one and this as well. That means this is bradycardia. And how can we make out that? We just calculate heart rate with the formula 300 divided by number of the boxes. So 1, 2, 3, 4, 5, 6 and 7. So 300 by 7, it comes at around 42 heart rate. So which is on the lower side, which is bradycardia obviously. So in this video, we'll be discussing about different types of bradycardias and the blocks that we see in the AV node. And next time you are in your ED, you should know how to manage such kind of patient. All right, so let's just begin with this. Before we jump into the proper clinical setup, how are we going to manage? Let's just take a look. What are the different kinds which can lead to such kind of situations? So there can be few medications that can cause this. So beta blockers, calcium channel blockers, digoxin. Okay, so it's important that you always ask the patient's history. Is that person is on such kind of medications? Or there can be due to subarachnoid hemorrhage. So in subarachnoid hemorrhage, there is a triad called as the Cushing's triad, where the heart rate of the patient is low, the BP is on the higher side, and there is irregular breathing. We'll be discussing subarachnoid hemorrhage in the neurology cases. And the other very important cause of heart block is or the bradyarrhythmia is hypothyroidism. See, what happens is that hypothyroidism, thyroid is a hormone which maintains the metabolic system of our complete body. So when thyroid goes low, the heart also starts pumping at a lower basal rate. So the heart rate drops. So you always need to rule out if the person has thyroidism or not. Or there can be some kind of MI or some Lyme's disease which can cause all this. So now we are done with what situations can cause this. Let's just take a look at the different types of ECGs that we can encounter in a patient who has a heart rate less than 50. So and then one ECG that I have shown you is the normal one, and the other we saw is of bradycardia. See, every ECG that is shown here is of bradycardia. We just need to differentiate what different kinds of ECGs can present. So if you take a look, see, this one is the P wave, this one is the QRS complex, this complete, and here as well we can see the P wave, QRS, P wave, QRS, P wave, QRS. So every P wave is followed by a QRS. You just need to first of all see this. So every P wave is followed by QRS. Okay, next step. Next, you have to see that what is our PR interval. So PR interval is normal. It's not that wide. It's not prolonged. So the PR interval. Okay, so if both of these are fine, the P is followed by QRS and the PR interval is perfect, you call it a sinus bradycardia, right? But let's just take a look at this ECG. If first of all we take a look at every P has QRS, every P has QRS, every P has QRS, but the PR has been prolonged, but the prolongation is equal. So this is first degree AV block. Okay, so the PR is prolonged, but the prolongation is equal. So let's take a look at the other ECG. See, P QRS, P QRS, and P QRS, P no QRS, P QRS. So one QRS complex is dropped. Now we are dealing with something else, not the first degree. Okay, so and also the PR prolongation is continuously increasing, and after a maximum prolongation, one P wave is not followed by the QRS. So we call this as second degree AV block. And the second degree AV block is also divided into two types. The one that we have studied now is the MOBITZ 1, and the one that we'll be studying next is the MOBITZ 2. See, in MOBITZ 2, P QRS, P QRS, P QRS, P no QRS, P QRS. But the difference is the PR interval is the same. It's not progressively increasing. So this is called as the MOBITZ 2. And this ECG is another variant of second degree AV block. See, every P is followed by QRS, but this is dropped. QRS, this is dropped. So for every 2 P waves, 1 QRS is dropped. So this is second degree AV block with 2:1 ratio. This is not important, but the MOBITZ 1 and 2 is important. And in this ECG, you can see that there is no relation between the P and the QRS. There is no relationship. So this is called as the third degree AV block. So now we are well aware with the ECGs, with the different types of ECGs that we can encounter. And let's just see this ECG as well. Can you see that here we can see a bradycardia-like situation, and here we can see a normal or a tachycardia situation, and again we have bradycardia situation. This is called as the tachybrady syndrome. This is not that important, just you need to just have a clue about it. And just take a look at this. P wave is followed by QRS, and then T wave, and then after a long pause, which is of more than 2 seconds, there has been no waves. This is called as sinus pause or sinus arrest, right? So this is just for your information. Let's just proceed to the treatment. After we are clear with the types of ECGs, with the causes of bradycardias, and with a little two variants of bradycardia, let's just proceed to the treatment. See, you have to first of all know what is your patient. See, any patient, let's just assume our same old guy, 45-year-old male, he's walking to your clinic and you check his heart rate, it is less than 50. Okay, so now you have to see whether my patient is stable or unstable. So let's assume that your patient is not stable. Stable means that he's not currently experiencing any kinds of dizziness, any kinds of syncope, and he's conscious, he's talking to you. So why to just, inject drugs into him? Let's just proceed with treatment of what is causing this bradycardia. So what you do is, if your patient is stable, you just reassure the patient, tell the patient, yes, we have found a problem in you, but we'll treat that as well. And then you treat the cause. And we have already studied the cause, right? It can be due to some medications, it can be due to some thyroid issues, or many other causes. You have to, take history, examine the patient and know what's the cause. Now, let's see, the patient is unstable, he's unconscious, he's in syncope, he's dizzy. So are you going to waste time on finding the cause and then you ultimately lose the patient? No, right? You have to inject something, and that wonder drug is atropine. Okay, and atropine you have to inject, and you can repeat it every 3 to 5 minutes, and maximum you can give only 3 mg, right? After this, you're not going to inject atropine. And after you have repeated, you can give 1 mg of atropine, and you have repeated it, let's say 3 times, because maximum you can give is 3 mg after 3 to 5 minutes. See, if the patient is not improving, you put a better drug, that is epinephrine or adrenaline, one and the same thing. Still the patient is not improving, go for dopamine. Still the patient is not improving. See, you have trailed so many drugs, atropine, epinephrine, dopamine, and nothing is helping. You should, immediately go for a procedure which is called as transcutaneous pacing. You put a pacer directly through the skin. That is called as transcutaneous pacing. We are doing it transcutaneously because it is quick and we need it. And after that, we are going to put a permanent pacemaker. Okay, and there are various different names for these devices. Let's just take a look. Permanent pacemaker is also called as IV pacemaker. It is also called as ICD, which is implantable cardioverter defibrillator, or it is also called as transvenous pacing. Okay, and see, these are the ideal conditions that I've told you, that in stable patients you go for this, and in unstable patients that you go for all the drugs and treatment. See, there might be some situations where you have to treat the stable patient as well. So this is a special case scenario. So even if your patient is stable, but on ECG you see a second degree MOBITZ 2, and you know as a doctor that this is dangerous, are you waiting for the history taking and the examination to complete and losing the patient in some time in front of your eyes? No, right? You have to proceed with some treatment because you know this is not going to help and this is not going to improve with reassurance or treating the cause. Or if there is third degree AV block, or there is a tachybrady syndrome, but the pause is very long, like the pause is for more than 6 seconds if asymptomatic, or more than 3 seconds if symptomatic. So these were the treatment guidelines for bradycardia, and the important ECGs that you need to know, and how to approach that patient. So I hope after this you'll be able to perform better in your ED postings and treat a patient with bradycardia.